I'm honored and privileged to introduce Dr. Kyle Cassling, one of our absolute stars in the Department of Surgery, who serves as a minimally invasive bariatric surgeon here at CMC Bergen campus and Emmanuel Hospital, and also serves as a core faculty under the leadership of Dr. Patel. Dr. Cassling is an Omaha native. She received her medical degree with distinction from the University of Nebraska Medical Center, followed by a general surgery residency at Vanderbilt University Medical Center. During her training, she completed a master's in education at Vanderbilt's University Peabody College. She also completed an advanced fellowship in GI, MIS, and bariatric surgery at The Ohio State Medical Center and is board certified in general surgery. She's actively involved in research, teaching, and community service. She's made several contributions to surgery throughout her publication, oral and poster presentation, and participated in many professional societies, including the American College of Surgeons, American Women Association of Women Surgeons, and the Association of Surgical Education. Her areas of interest are MIS, minimally invasive surgery, bariatrics, surgical education, wellness, and also how to leverage arts to enhance care and education. Since her arrival, she's done an amazing job in the Department of Surgery. She received the Faculty Teaching Award within 10 months of her arrival, which is a testament to her commitment to surgical education. She's also been an outstanding champion of the American Board of Surgery, EPA. Her research agenda is unique and innovative, is how to roll out robotic versus laparoscopic surgery in rural settings. And she's mentored many of our residents and students, and I'm thankful and grateful for her expertise. Today, Dr. Cassling is going to give us a ground round about observation with purpose, enhancing assessment and practice. And also, I want to welcome our applicants on Zoom who are interviewing with us today. Let's also give them a warm welcome and to our program. Dr. Cassling, no further ado, I introduce. Thank you.
Okay. Thank you for getting something. Is working? Can you guys hear me? No. Okay. Okay, how about now? Perfect. So, good morning, everyone. Especially want to welcome our applicants who are joining over Zoom for tuning in to Grand Rounds. We're very much looking forward to speaking to you later this morning during our interviews. And we're going to go ahead and get started. So to begin, this will actually advance. I've got no financial disclosures, but as Dr. Patel, I feel like always says, definitely open if anyone has anything to offer. I also want to disclose that there's a lot of credit from these slides and this topic that I'd like to give out to the ACGME. Dr. DeRosa and I just attended the Faculty Competencies and Assessment course. So I really appreciate everything that we learned there and the developing faculty of that course and the facilitators of that course. So to start with, I wanted to focus on a topic today that's related to surgical education. Last year, we were really fortunate to be visited by Dr. Terhune. For those of you who don't remember, that's what she looks like. When she came to visit, she talked to us about feedback and gave a really excellent review of how to give feedback, how to receive it, and underlying the theme of how feedback is ultimately the most important thing for the care of our patients. What I'd like to do is step back a little bit in time and think about what happens before you give that feedback. This talk was really heavily inspired and influenced by the course that I just mentioned that Dr. DeRosa and I attended. Dr. Patel has also attended this course in the past. There's going to be some audience participation. So any of you who are geographically close to either Dr. Patel or Dr. DeRosa right now have an excellent tool in your back pocket, so please use them. But we're going to start with kind of catching everyone else on the agenda for this morning. So the focus of this morning is going to be on the idea that direct observation is here. We're doing it already, but there's ways that we can optimize it. So here are my objectives. We're going to define competency-based medical education, or CBME. We're going to explore challenges in how we orient assessments within this realm of CBME. We're going to describe the role of direct observation in assessment overall. We'll talk a little bit about some barriers and some errors that can happen when we're doing direct observation. And then finally, the most important thing is we're going to outline and practice some strategies for how we do really purposeful and effective direct observation. So taking note of these agenda items, the Ignatian value I'd like to highlight for this morning is MAGIS, which means greater or better. So it's a focus on quality over quantity. It means to strive for betterment in all things. And with so many topics in surgical education, many of which we already do very, very well here at Creighton, there's still always room for ways we can enhance our practices. So to start with, let's talk a little bit about competency-based medical education. So CBME is not a new thing. It was initially described in the 1990s. And this quote really kind of gives a good overview of what it means. So it's an approach to education in which decisions about a curriculum are driven by the outcomes that learners should display by the end of their training. The most important part of this quote is that in outcome-based education, the product is really what defines the process. The outcomes are clearly specified, and decisions about the content and how it's organized, the educational strategies, the teaching methods, the assessment procedures, and the educational environment are all made within the context of the stated learning objectives. So again, really just to emphasize, the main key of competency-based medical education is that the outcomes, the goal, what we want trainees to be able to do on their own independently is really what defines this process. It's a framework that's entirely based on the outcomes, right, of our trainees, and most importantly for our patients. These outcomes then shape the curriculum, our assessment processes, its features, the learning environment. One way to think about it most simply is kind of about a shift away from thinking about time as a measure of competence, and instead thinking about time as a resource with which we use to achieve something, whatever that goal might be. In competency-based medical education, time is really exchanged for flexibility, but it's also exchanged for accountability. So accountability between faculty and trainees, and also accountability, most importantly, to our patients. For this whole schema to actually work, we really have to believe in this idea of a growth mindset. This idea that faculty, trainees, anyone really can experience growth and development through frequent and formative feedback. So in a practical sense, what does this mean for a residency program? In ACGME language, we use a framework of core components that are known as the core competencies that all of us maybe should, maybe already do, know and can name. There's 6 of them that we pay attention to. There's patient care and procedural skills, medical knowledge and clinical reasoning, professionalism, interpersonal skills and communication, problem-based learning and improvement, and systems-based practice. All of these competencies really describe what our desired outcomes are for a graduate of this program. We need a graduate to be able to practice each of these domains in a manner that they can do so without supervision by the time they're finished. But they aren't always the entire scope. So there's also this concept that that's not the totality of practice or the discipline. It doesn't include all components of professional development. So there are some limits to this type of a framework. One way to think about the transformation along each of these components, like the scaffolding, is along something called a learning curve. So this learning curve in particular is intended to kind of demonstrate the progression that someone might make along any of these competencies. So it's someone who's hitting each of these milestones as they progress through time and experience. They show growth, right? This idea of a growth mindset from a novice to someone who is advanced, to competent, to proficient, and to expert. And notably, the goal is not expert. When we finish training, right, no one is an expert. Our goal is for them to be proficient, to be able to practice without any type of supervision. So when we think about how we do assessments in this framework of CBME and with these core competencies, we have to figure out how we make appropriate assessments that actually match our goals to make an assessment that is fit for purpose. As you can imagine, there's lots of challenges in coming up with these types of assessments, but the key is always to come back to that central premise that we talked about already with competency-based medical education. It's all about how the assessments too have to be fit for purpose. Any assessment has to be designed to actually measure and evaluate what our desired outcome is, and we want the right tool for the competency being assessed to fit within the broader assessment too of the program. There's lots of challenges in creating assessment tools, not exclusively the focus of today, but we'll talk a little bit about them because they'll be something we call back again when we're practicing some of our skills later today. So some of the challenges that come to mind are things like reliability, right? So needing consistency in a tool across time. So that top graph or graphical representation is something that's not reliable, right? The dots are all over the place and it's also not valid. So validity is another challenge. It turns out that's important for a tool to be valid. It needs to actually capture the reality of what's happening. So that top image is something that's not reliable and it's also not valid. The dots are all over the place and they're also not hitting the target. That middle one, right, is something that's reliable. Everyone seems to have agreement about what's maybe going on, but it's maybe not what's actually happening. It's not valid. The bottom is what we're ultimately looking for, something that's reliable and something that's valid. Other challenges are things like feasibility. So you have to have, if you have a great tool, it has to be the best tool in the world. If no one's going to use it and they can't integrate it into their day-to-day life, it's not going to be helpful or effective. And then finally, acceptability. So the idea that a tool should be actually suitable to folks who are using it. This is related to issues like ease of use, time required, comfort, burden, clarity, etc. Overcoming these challenges can lead to tools that have almost like a catalytic effect, whereby the assessment provides results and feedback that ultimately creates, enhances, and supports education. So it drives learning forward. There's lots of assessment tools that we use every single day. Everyone uses them. So I'm going to call for some audience participation. Think about, for the students, while you're in your clerkship, what tools have maybe your residents used or faculty used to help evaluate your progress? For residents, when you're on a rotation, what kind of feedback do you get? What tools are being used? How do you maybe give feedback and assess your peers, assessment of students? And then same question for faculty. And if no one volunteers, I know most of your names. So I will start calling on people.
I'm at the VA with Dr. Matt Burns, and he gives actually pretty good feedback unsolicited, like twice a week.
Unsolicited. There we go. Dr. Barons gives feedback based on what assessment tools? What are you using to help give that feedback?
There'll be pretty immediate feedback right during this presentation. If there's something that's a little bit off, we can just kind of correct it. And there'll be every once in a while, just shortly after, we'll kind of go kind of debrief on it and say, you know, how do you think that went? And we can kind of go from there as far as stuff that we both think may need to be improved upon.
Perfect. So it sounds like you're watching behaviors and you're giving feedback based on those behaviors, which is excellent. How about maybe a test that happens every January? What's that test called? I know you know it. Don't whisper it. ABSITE, right? That's also an assessment tool. How about other things? What ridiculous star chart do I put up every week? Simples and EPAs, right? Those are also active ways we get assessments every single day. So one way to think about organizing assessment tools is using this type of a diagram. So this is called Miller's Pyramid. It helps organize assessment tools based on their intended outcomes, right? Our outcomes being someone who knows things, knows how to do things, knows how to show how to do things, does things, and is trusted to do things independently or without supervision. So if we want to get a little bit more of a detailed view, these are some examples of assessment tools and how they fit with their purpose, right? Demonstrating all of these abilities here. So some assessment that assesses knowledge, right? Knowing that someone can do something is multiple choice questions, right? An ABSITE test or taking TrueLearn questions or using a study bank, right? That is a way to assess knowledge. Knows how to do something might look like oral board prep or oral exams, using diagnostic reasoning skills, things like that. Shows how, so some of this happens maybe in a simulation center. So doing simulated procedures, working on the laparoscopic box trainer, working on the robot simulator, the endoscopy simulator, things like, oh my gosh, now I'm totally blanking on the tests that we have to take for laparoscopy skills and endoscopy skills. FLS and FES, thank you. And then finally does, which is the peak of the pyramid, right? This is the most important thing. This is watching people actually do a task. And this is where direct observation is important. So really at the top of this pyramid, perhaps the most important thing is seeing people do stuff in real time, making note of it, and being able to give effective feedback on that observation. So the main focus of the rest of our time is going to be the idea of direct observation. Again, it lives at the top of this pyramid back here. And we're already doing this, right? We literally watch people do stuff every single day. We're really good about doing it in the operating room, right? Because this is what we've been using to keep track of that. The importance of direct observation is that it shows a lot of promise. It definitely is fit for purpose, right? It's malleable, it's flexible, and I hope I can convince you it can be used in all manner of contexts, not just in the operating room, but outside of the operating room too. And it fits within our broader assessment program. It's feasible. We don't have to go to any new or unusual clinical context that we're not already in every day. It can happen in your day-to-day activities. We're also already doing a lot of it, like I mentioned, with simple and EPAs. And we've been making some really good strides in documenting those observations, right? I do the annoying star chart every week to keep track of those things. So my title with the talk being Observation with Purpose is really meaning two things: to expand the arena in which we are already doing meaningful observation, and to use some new tools to make that observation high quality and translatable into actionable, high quality assessments and feedback. The biggest takeaway, I think, and I'd be curious if Dr. DeRosa and Dr. Patel agree with me, when I left that ECGM course, that everyone seems to be intentionally doing this a lot better than surgeons are doing this. So it was a room full of practitioners from all sorts of specialties, right? Family medicine, internal medicine, pediatrics, radiology, and in particular, our colleagues in those really primary care settings do this exceptionally well already. This is built into how they practice, it's built into how they work with residents. So it was really cool to hear about their experience and how they use certain tips and tricks for how to make it possible. And then one thing we spent a lot of time talking about were some of the barriers to purposeful, high quality direct observation. Some of the barriers we'll touch on are related to faculty challenges. Some of them are related to learner challenges. So for faculty in particular, time is always a barrier for literally everything. So limited time is a big barrier for doing high quality observation. Lack of a buy-in. So I'm going to try to convince you this morning that this is important. There's some fear that it could undermine the patient-learner relationship. Like, what does it mean if I'm going to be sitting in the corner in a clinic visit or in the ED room while someone is getting a history? Is that going to impact the relationship that the patient is able to develop with the resident? There's also this idea of a variety of experience with assessment. Anyone familiar with this idea of doves versus hawks? And people who are doing evaluations. So this is a type of like distributional error. So this means that there's variety in stringency or leniency of someone who's doing an assessment or giving critical feedback, meaning that some faculty may be doves, right? They're maybe softer in their delivery of feedback or more positive in the outlook of the feedback, where others are hawks and more severe, harsh, directed. And then finally, there's also always kind of social or human factors, things like stereotyping, issues of cognitive load, right? Being able to observe all the things all at once and also effectively give feedback on all of the things all at once. And then finally, this idea of like a halo or horn effect. Anyone familiar with what that means or heard of those terms come before? So that means an assessor's perception of a learner's abilities or qualities or personality is going to shape their evaluation. So if someone has a halo effect, someone has maybe heard, oh, this person is phenomenal, they're going to do great. That then colors how they might assess that person. Versus if someone has horns, oh, they've got a terrible reputation, yada, 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 may or may not be true, right? But it's definitely going to color how that observation goes and how that feedback potentially goes. And then there's also barriers for learners to participate in direct observation. Again, time always comes back to time. Concerns about limited trust. It's also anxiety provoking. It doesn't feel good when someone's watching you do stuff, right? That's what makes a lot of people nervous about doing oral boards prep or doing oral boards, right? You're being watched very carefully and very closely. Same thing in the OR. There's a lot of this idea of box checking. So the feeling that you're just doing a task to check a box and get it done with. And then perhaps the biggest barrier is kind of this idea of threat to autonomy. So this concern that if an observation goes poorly, like if the performance is not what I expect it to be, am I ever going to be able to be trusted to do that activity again to the same degree of supervision that I just did? So with these barriers and challenges in mind, and knowing that there's some limits on our assessments, I'd like to work on some kind of application tools and strategies so we can perform more purposeful observation in everyday clinical life, just on a day-to-day basis. And these strategies take the form of a sequential series of tasks that we're going to work through. So we'll talk about them first, and then we're going to practice them. So these tasks are to create a shared mental model, to introduce an evidence-based framework to perform an observation, to watch someone do something, to then synthesize that observation, to assign some degree of entrustment, to give feedback, and come up with an action plan, which is a collaborative part of this process. So the first step is to create a shared mental model. So a shared mental model, or a mental model in general, is some type of shared understanding or representation of a team, of individual team member tasks, and how the team might coordinate to achieve a goal. Individual team members can have varying degrees of overlap or sharedness among the mental model of the team, but everyone kind of has a general idea about what our purpose is. So this little cartoon was also stolen from the ACGME, a dog and a cat staring at a corner, and no one knows what they're looking at. So first step is to try to figure out what we actually are looking at and what we intend to measure and capture. So shared mental models share three main features. They are accurate reflections of effective educational and clinical practice and current reality. It's based on the best available evidence and correct assumptions. There has to be agreement between the members who are coming up with a shared mental model about the actual goal, right? Again, fit for purpose, it's all about outcomes and how the group will achieve that goal, like what assessment practices we're going to use. And then finally, there has to be a description of how the group, faculty, the program at whole, maybe the CCC, are going to work together to achieve these goals. So an exercise to come up with a little bit of a shared mental model is this thing called performance dimension training. Performance dimension training involves 3 steps. The first one is to identify some dimension of a core competency that can be described as a behavior or a set of behaviors. So like the steps of gathering a history, getting informed consent, breaking bad news, things like that. The second step is to break it down into a set of behaviors that can be evaluated individually to better understand someone's performance and assign them a level of competency, right? An entrustment level, whether they will be trusted to do this with a certain degree of observation or supervision. And then finally, it's to compare what you generated to an evidence-based model. So in total, this process creates a shared understanding of what behaviors need to be demonstrated by someone to be deemed competent at any given component of those 6 ACGME core competencies. In other words, everyone is on the same page about what a good performance is of taking a history, breaking bad news, doing consent, things like that, specifically from a behavior standpoint. So this is the beginning of our more participatory part of this talk. So I'm going to have you guys break up into small groups, 4 or 5 people per group. And I'm going to ask that you develop a list of behaviors, emphasis on behaviors, that would exemplify a good performance, an adequate performance, a competent performance of gathering a history. So think about what you would expect maybe a graduating resident to do during their initial assessment of on behaviors. So I'm going to ask that our lovely volunteers hand out the first sheet, yes, to some groups of 4 to 5 people. And you're going to do 2 things. You're going to identify the components of an exemplary taking of a history, meaning thinking what should be asked, what should be done, how should it be asked, how should it be done, and then frame those things within the language of a behavior, something that you can observe, check a box to see yes, no, was it done? So it's something that's measurable.
I know Amy did a great job, mother. You don't think of it by itself.
Okay, we'll break through for another minute and okay. Assign someone to represent to the group. Okay, here's. We're gonna move here. Probably your menu option. That's. Okay, bring it. Who wants to volunteer one of the components of this great together? One person from each group.
Yeah, so I think first thing we talked about is establishing like courtesy and respect right when you walk into the room, introducing yourself to the patient, kind of like setting yourself up to establish a good working thing.
Yeah.
Ensuring privacy.
Perfect. So, right, we're introducing yourself to the patient, ensuring that there's privacy for the encounter, right? Both of those things would I think appropriately fall under a category of like professionalism or interpersonal interactions. What other things? You do have, okay.
We talked about thoroughness, so starting with broad open-ended questions and then going into more narrow questions.
Yeah, so type of questions that are being asked, that's definitely behavior. Fall into maybe data gathering as an activity.
We talked about are the patient needs met, like do they have their glasses on, is there good lighting so you can like see them, they can see you, do you have an interpreter?
Yeah,
So just basically meeting their needs, are their hearing aids in?
perfect. I like all of those suggestions.
We talk about things like open body language, so using eye contact.
Perfect. Again, behaviors that are recognizable, like you could tell if someone's making eye contact with someone or not. James Hazen.
So I think a lot of these things that we talk about all fall under what our team said is like setting the scene or staging the encounter, getting rid of distractions. We talked about privacy. We talked about like is the hunt blaring? Are there alarms going on? Is the TV loud and no one can hear you? Who's in the room with you? Making sure that you like introduce yourself to the patient, like what the purpose of your little visit or chat is if it's not abundantly clear depending on the context.
Perfect. Yeah. So setting the agenda is kind of what I heard, right? Establishing what the goal of the visit is, what your goal is, the doctor is, what the patient's goal is. Any other suggestions?
One of the things that we talked about was at the conclusion of the history taking, summarizing with the patient what they told you, what you maybe know, like test results that they haven't heard, sort of at the conclusion, and then assessing the patient's understanding.
Yeah, definitely. That's excellent.
We talked a little bit about just like minimizing, for example, like someone said minimizing distractions, but keeping the screens of like computers, phones, or whatever, like out of your interaction with the patient as much as possible. Or if you absolutely need it, at least sort of like set the expectation of like, I'm going to be taking some notes, or like I have your imaging up here so I can reference it as we talk, but just I'm paying attention to you.
Yeah, addressing technology in the room. Super important, right? Because every room has a computer. Anyone from our CT group over in the corner?
Yeah, I mean, we agree with what's already said.
Perfect.
Also, assessing the patient's healthcare literacy is important, and also patient understanding of why they're seeing you and what the problem is.
Yeah, definitely goes back to that kind of agenda setting, making sure everyone's on the same page, making sure they understand. So the next handout we have is the last step of this performance dimension training. So this is actually comparing, forgot to go ahead, slides. Comparing what we just created as a framework together to an evidence-based model. So we've got one more handout if we can hand that out. It's got a bunch of lists of things categorized by groups of behaviors that might happen in an exceptional demonstration of gathering history. So here's what that looks like. I know it's really tiny, but there's some handouts coming along. So take a brief look, see if there's anything that you feel like we missed. Is there anything wild and crazy on this list that you're like, wow, I hadn't even thought about that as something that should be happening during a history taking? We'll take just a couple minutes to review this evidence-based framework.
We address what each patient might prefer, or introduces their patient. I introduce myself to the patient every morning because they never know me at all. No, you're the best. Most likely. And by the way, you have another orange juice. Starts with social. Literally all the Starts with social talk, small talk. Patience and stuff. Interview, makes eye contact, uses open body language. Take us with comfortable.
Maybe a conversation. Start off from like a conflict where when I'm on patients.
Okay, who was surprised by the length of this list? And the things that were included? Anything in particular stand out? I feel like we touched on a lot of things, right? We talked about setting the stage. We talked about setting, starting an agenda, non-focusing questions, open-ended questions, getting into more narrow things, checking for accuracy, checking for understanding. So we hit some of the highlights. Anything surprising that you guys saw in this framework?
The CT surgery group would like to say, there should actually be a proper interpreter present.
Yeah, I love that.
Okay, there you go.
The only other element that I saw just lacking was nowhere near does it really describe establishment of trust between the patient and the clinician, because all this may not matter if they don't trust you, if they don't feel like you're being empathetic towards them.
Sure.
They actually want to and care to be there to help.
Yeah, and that's where it gets tricky, right? Because it's hard to assign like one single behavior as like I'm establishing trust with my patient. It's probably more like a group of things that is where we get into the weeds a little bit, and being able to really explicitly say this is a behavior that I saw someone do and can make a comment on, and how that relates to what the ultimate goal is, right? And creating a trusting relationship with your patient. Anything else surprising that people saw?
We talked about how this was kind of demonstrates how this is dynamic in terms of specifically with like the use of the EHR and how like the technology we use in the medical setting is going to change how our behavior in history taking must change also. Whereas 30 years ago we didn't have the EHR, we probably would talk about this, but now we should be more open about explaining what we're doing when we're logging into the computer at the patient's bedside to say look at images or review lab values.
Yeah, definitely. All excellent points. Okay, so now that we have this in mind, we have an idea about what we are looking for, right? We have a shared mental model. We're going to do a little observation. I'm going to make a suggestion. We're going to watch a video. I want you to think about what you see in terms of behaviors into two categories: what the simulated resident did well, and what they could be improving on. Focus again on behaviors, so things that you physically witnessed this resident do with a simulated patient, and write down what they did well, what could be improved on. So hopefully this video will work, and hopefully the sound quality will come across. Seems like the audio is not working.
The audio never works on the system as well.
Okay. Is there a way we can troubleshoot this?
I wish I had a fix.
Should I see if I can play it just from my browser, maybe? Because I don't want to just play it from the audio of my computer, ideally.
Try it.
I mean, I could try to turn it all the way up.
Hello, Mr. Eckers? Yeah.
That's a bad idea. Anyone have any ideas?
Are you sharing? You can try sharing.
Yeah,
the-
my audio is all the way off now because it was making it very echoey.
Is your mic on? Try your-
Just mute your computer and then share it in Zoom.
It'll still catch on the room audio.
Try sharing just that application instead of the whole computer.
Just the.
Yeah, try and reshare. Sometimes that doesn't play.
Then you went down.
The likelihood of me fixing something that Dylan says is a continued problem.
Yeah, unfortunately, I've tried. I can never get audio to actually play over this room.
Watch their body language.
Yeah.
Some people do this.
No.
Did you shower?
I mean, what if I just do this?
Is everyone doing it home?
No, that's gonna make it worse.
That sounds like it was coming out.
Actually sounded great.
Just a second to line.
because I feel like we've got some things that we can touch on. So first, anyone want to volunteer what we think this resident did well?
I think a lot of times as when I was a student and as a resident, we attempted to just pause more than like a second or a second and a half, attempted to fill the silence, especially if you're leading the conversation. So there was at least 1 or 2 times where and let the silence sit for a minute.
Yeah. Okay, how about things that maybe could be improved? Go on again. Correct, just flew right by that. So this is what I put down, right? The resident greeted the patient. They thanked the patient for waiting. They did summarize their history, checked for accuracy. I think that's at the end, so we didn't actually see that. And they used some statements of empathy. So at one point he said, "I'm sorry to hear about that. That must be hard." But really, his voice and facial expressions didn't really match this feeling here, right? He said those words, but maybe his face and his interactions in the room didn't match that. Like mentioned, he quickly moved to very closed-ended questions, asking check boxes. Is it this? Do you have this? Do you have this? Do you have this? And then he also didn't stop typing when the patient asked about job loss. So if you had to pick maybe a couple to focus on, say you were going to give this resident some feedback, you want to pick just a couple things. So I just picked these issues related to maybe demonstrating behaviors of empathy, showing that this resident cares about this patient, because I believe he probably does, right? I sure hope he does. And orient that feedback and this conversation around what we can do to improve those behaviors, make this relationship a little bit more, improve it from a patient perspective. So the next step is to synthesize the observation. We're running a little bit short on time. So I'm just going to tell you how I synthesized this observation, but the goal is to do it into like 1 to 2 sentences. So I said the resident introduced themselves to the patient and characterized the patient's primary complaint using largely closed-ended questions, but they did check for accuracy with the patient. The resident expressed some statements of empathy, but their tone and behaviors did not match those statements. So encompasses the behaviors that we physically saw in this interaction. So based on that observation of this really short history, how much entrustment would you give this theoretical resident? Do you think they can be there, but just watch someone else get a history? Can they do this skill while being watched again? Can they practice the skill with indirect supervision? Maybe means that their faculty member is sitting in the clinic outside of the exam room and then comes back to verify the history later. Or can they do unsupervised practice? What do we think? Katie's throwing up a peace sign. For 2. Who else thinks maybe direct observation? They've got some elements of this skill down, but room for improvement, and they should probably be observed doing it again so they can continue to work on those things. That's what I said. So how do we tell the resident this feedback, right? How do we tell this theoretical acting resident what we think they should work on? One model, and we're not going to go into all the details, is this model that's called ADAPT. It stands for ask, discuss, ask, and plan together. So when we think about the steps of this model, you ask in the beginning an open-ended question, how do you think that went? What was that interaction like? You then discuss what the maybe person you were watching, what their self-assessment might have been. You ask them, what do you think what went well? What do you think you want to work on? And you share your observations. So this would be a time to share what that summary statement was and say, I thought you did well at introducing yourself. You did share some statements of empathy. I would like to talk a little bit more about how we match statements of empathy with behaviors that might support that so the patient feels like you genuinely care about their problems. And then you ask again, you say, what are your thoughts about that feedback? Was it fair feedback? Do they see where you're coming from? And then the most important thing is to plan together. This is where that evidence-based framework can be really helpful. So planning together, the simplest way to do it is to say, I'm going to pick one thing on this evidence-based framework, and I want us to collaborate and come up with a plan for how we can improve your performance specifically related to that behavior, right? It makes it very explicit. Again, it's focused on behaviors, not attitudes and other things. So you might ask, how are you going to work on this certain thing? Who can help you with that change? Here are some suggestions from like my experience, asking about maybe what barriers would get in the way. That action plan is kind of that formal component of the plan together model from the ADAPT. It's a collaborative process. And again, consider using elements from the evidence-based framework for just some structure and organize things, especially if you have a hard time figuring out what you actually saw. Rely on that evidence-based framework as a scaffold. So again, if I was going to give feedback, maybe I would focus on this box down here. So using skills to elicit symptom story, personal and emotional content, pick one of those and organize the feedback around that specific behavior. So tips and tricks. This is kind of the takeaways from the other people who are at the course, family practitioners, internal medicine folks, pediatricians. They suggested just observe one skill at a time. Don't try to look at everything. So one way you can do this is think about, I'm going to go watch someone do a history for a new consult in the ED. I'm going to go watch a new patient visit. I'm going to do maybe a post-op visit or do something on rounds. Similarly, for steps of counseling procedures. Practically, someone's advice was to only observe for as long as it takes to identify 3 things and then walk out of the room, right? Time is valuable. That's a huge limit. Watch for a short time. Make your little notes in that, what went well, what needs improvement. Once you get 3, leave. And then try to make your observations focused on what that trainee's goals and objectives are. So you might ask something like, who's the most challenging patient on service right now? Is it okay if I go watch you interact with them? What are you working on? What do you want feedback on? So again, as a recap for how we make direct observation purposeful, helpful, help us get high quality data, it's to identify areas of strength and areas for improvement, prioritize that list for what you want to give feedback on, synthesize it into a theme, some type of summary statement, assign a developmental level, meaning decide the next time a similar event presents itself, what level of entrustment are you going to give this trainee, and then prepare for feedback and identify an action plan in a collaborative way. So we already do direct observation. It's already in our wheelhouse. These frameworks that we discussed are analogous to what we already do with SIMPLES and EPAs, right? We observe something in the operating room, we synthesize the performance, we give some type of narrative feedback, and then we literally assign an entrustment level. So we already have the language to do this. We can build on these existing skills to environments that are outside of the operating room because EPAs happen outside of the OR. EPAs happen for consults, EPAs happen for pre and post-op care too. So in total, I hope you've gathered that competency-based medical education is all about orienting curriculum, assessments, and environments to our goal outcome. Assessments have to be fit for purpose, otherwise they're kind of useless. Direct observation is underutilized outside of the operating room, and there's lots of strategies to make what we already observe more purposeful for peers, trainees, and our current and future patients. I shared this slide last time I gave a grand rounds because Dr. Tarpley is near and dear to my heart. He has lots of sayings. I felt like a lot of them fit with this talk as well. So getting into the habit of having good habits, experience is inevitable, learning is not, and the getting is in the giving. And then just some more fun photos of all the people who taught me how to do all these things. And I'll take any questions.
One of the really interesting things I think you said was this like concern about losing autonomy. That really resonated with me because I feel like as a second year, I'm starting to get to do things and I can feel myself thinking, don't mess this up or else you won't get to do it again. And I had never heard that like thought of loss of autonomy. As someone who is like on the other side of that interaction, say like you give someone this new level of autonomy in the OR and you feel like they aren't quite there, what are the things that the learner can do to kind of get back to that level of autonomy? Does that question make sense?
Yeah, it makes sense. I'm going to reflect on my own experience then transitioning from being a resident to a fellow, like going to work in a new program with new faculty that I've never worked with before. And those faculty have no real conception or understanding of what autonomy I was granted as a trainee in residency, right? So those worlds do not interact. The way I bridged that divide, particularly with faculty who were very specific about what they wanted in the operating room, was the strategy I found that was helpful was to think out loud. Just say everything that I was thinking, every step I was going to take. So then that person knew what I was literally thinking about doing next. Saying things out loud, making them understand that, oh yeah, I know what the next step is going to be. And then let me do it. So that was my strategy that I helped, to navigate that bridge, if that makes sense.
Thank you. Other questions? Dr. DeRosa.
And I think that we hardly ever use direct observation outside of the operating. And yet we always say that the most important parts of becoming a surgeon happen outside of the operating room.
So making decisions, I don't think does this work very well? Making decisions in clinic, consenting the patient. I mean, Dr. Ofetol, her like takeaway for her M&M this morning was like, I need to learn to ask these questions so I know how to take care of the patient after the surgery. This is, I think, a culture shift. How do you, as a member of the core faculty, expect to positively impact the culture here to affect this change?
That's a really hard question. Why does Dr. DeRosa always ask hard questions? I think this is step number one, right? So recognizing that this is a thing that other people are doing outside of the surgery world that we're behind on. And that was kind of the takeaway from the other surgeons who were at the course with us, right? Everyone kind of recognized that, yeah, we're really good at observing stuff in the operating room. That's what we already excel at. What we really need to catch up on is observing everything else that is super critical, if not maybe even more critical than what happens in the operating room. So I think first step is this, right? Recognizing that this is a area of improvement for us as a program. I would love to be able to do some more faculty development related to this. Dr. Alrafai has generously given me some time during our faculty meetings. I'm hoping to be able to use that to work on some of these skills. And the other component of this is, right, this whole half of the room, trainees, medical students, right? This is how we figure out if you are ready. So you are equally invested in this process as the faculty are. It is also, feedback evaluations are a two-way street. It means learning how to respond to feedback, accept feedback, but also how to ask for that feedback. So I think you have an equally important role in asking for assessments of how you're doing these skills outside of an operating room. So pushing the elephant from two directions, maybe, as it were.
Dr. Cassling, and thanking you for bringing this important topic. And I'm going to do a better job in being more observant with purpose and intention outside the operating room. What advice do you give the faculty where to start at? And can we, 3 steps? I believe in breaking things down to 3.
Yeah.
We do a good job in the operating room. I fundamentally agree with you. How clinic rounds and how do we start as faculty?
I also don't do this well yet either, right? So I need to also work on it. I really liked the example of a tip of saying, just watch something until you have 3 things to give some feedback on. You observe 3 behaviors, either that were excellent or that need some improvement, and then walk out of the room, right? It's hard to have a full clinic and also have the time to observe someone else. So that would be a tip that I'm planning on using. You want 3 things? I
more.
think so. I'm happy to share. There are other evidence-based frameworks. So this history taking framework. There's also other ones about physical exam and maybe was it like counseling? I think breaking bad news. There's several of them. So I think that can be a tool we can put in our back pocket and say, this is what I'm going to organize those thoughts around, right? Push the easy button, look at a list, give feedback based on those evidence-based frameworks. So maybe that's number 2. And then number 3, I think, is really being mindful that the other half of this equation, like I was saying earlier, is students, trainees, right? Really investing in encouraging your guys' involvement in this whole process, right? Because this doesn't happen with only faculty. You guys are the other half of this equation too. So being more open and mindful about explicitly asking, what do you want to get out of this operation? What do you want to get out of this clinic visit? What do you want to get out of XYZ activity?
Thank you. Thanks again for wonderful ground rounds.